Good morning. This is Ron Broussard. Today we'll be talking about Chapter 32, spine injuries and spine motion restriction. Now, with spinal injuries, spinal cord injuries, spinal column injuries, we have a lot of different mechanisms of injury here. So it just means you have to have a high index of suspicion on a lot of the trauma calls that you run. May it be a vehicle collision, may it be a fall, even from standing height for a geriatric patient, depending on how they fell. Could be an indicator for a spine motion restriction. Now, spine injuries include injuries to both the column, which is, the bones, all right, but also to the nervous system, meaning the spinal cord. Now, patients with spinal injuries must be handled so you avoid or reduce movement of the spine. In a sense, taking axial stabilization to reduce additional movement, and the whole purpose of that is to help reduce the risk of additional injury caused by us. Now, going over the anatomy and physiology real quick. So we have our nervous system, break it down into two major functions, okay? Communication and control. All right, meaning, our brain, spinal cord, and all those peripheral nerves that branch off send messages. One, they send messages sensory for the environment that we're in, whether it be, touch and what we're feeling, sensations to hot and cold, sensations to pain. Okay, all those sensory things send a message to the brain, and then our body is going to react accordingly. Okay, like if it's really, really cold, all right, what's going to happen? Well, you have those thermoreceptors that are going to pick up, the cold environment. It's going to send a message to the brain, specifically the hypothalamus. Remember, we talked about that a little bit with environmental emergencies. And then that's going to carry out a response for the body, right? Okay, hey, we're cold. All right, let's go ahead and start shivering. Let's go ahead and get goosebumps and make our hair stand up to try to hold hot air or warm air closer to our skin. All right, so understand we have that communication from sensory input from the outer environment, and then the control being what our brain wants us to then carry out. Okay, it enables awareness of and reaction to the environment, and also coordinates body responses to changes in the environment. Okay, so components of the central and peripheral nervous system. All right, we break it down into two systems. Okay, we have the central nervous system, which consists of the brain and spinal cord. Okay, and then we have the peripheral nervous system, which is all of the nerves that then branch off of the central nervous system. Okay, we have some divisions within the nervous system. So we have the voluntary nervous system, which we have control over. All right, if I want to go and pick up my phone and start messing around on the gram, all right, that's voluntary. I have control over that. All right, whereas autonomic functions, we don't actively think about. Okay, what I want you guys to think about here is like autonomic functions like digesting food. Well, you don't think about digesting food. You're not like, small intestines, I need you to increase peristalsis to move that, balled up bunch of food that I ate and down so I can process it. You're not thinking about that. What else are you not thinking about? Well, you're not thinking about constricting your blood vessels. You're not thinking about dilating your blood vessels. Okay, so there is, some things that go on in our body that we don't have control over that just carry on automatically. Okay, now those autonomic functions are influenced by sympathetic and the parasympathetic nervous system. Okay, when we think about it, sympathetic, remember that fight or flight, and parasympathetic, rest and digest, or whatever way you remember that. Sympathetics, remember, we're going to pick everything up. All right, so hey, our breathing rate might increase. It's going to send stimulus to the heart to increase heart rate. It's going to send a stimulus to the blood vessels to vasoconstrict. Not worried about digesting food, right? During a sympathetic fight or flight response, so saliva secretions are going to decrease. Peristalsis is going to decrease. All right, whereas parasympathetic stimulation, okay, that's kind of that rest and digest. We're bringing everything back down. That's going to slow the heart rate down. That's going to dilate blood vessels. Okay, big reason why a lot of people have hypertension is could be due to stress. So they're constantly under stress. Their body's constantly getting a dump of hormones, cortisol, epinephrine, all that stuff going through their body. And what is that doing to their blood vessels? Well, it's constricting their blood vessels, sympathetic. Okay, what is it doing to their heart rate? Well, it's increasing the heart rate, increasing the force of contractions, sympathetic. And what do we tell those people to do when they're stressed out? We tell them to try to, hey, relax, man, breathe, settle down. All right, and the goal is to hopefully, trigger that parasympathetic nervous system, slow the heart rate down, relax those blood vessels, and hopefully lower the pressure. That's just one example of, the nervous system and how it functions with sympathetic and parasympathetic stimulation. Okay, so the skeletal system, we have the skull, because of the cranium and face. We hit on our anatomy of the skull, previous slide. Remember, or not previous slide, previous chapter, but remember we only have one, movable joint in the skull, okay, and that's the mandible, the lower jaw. You still got to know all your bones, all right? So the frontal bone, parietal bone, occipital bone, temporal bones. Make sure you know the zygomatic bones, the maxilla, mandible, all right? So make sure you guys have a good understanding of those bones still. I know it's kind of a review from previous chapter, but make sure you're still comfortable with them. All right, the spinal column consists of 33 vertebrae with 5 divisions. Okay, vertebrae bound together by ligaments, and then vertebrae are separated by discs. All right, now with the spinal column, you guys will need to know, how many vertebrae are in each division. All right, so 33 in all. You have 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae. Okay, you have 5 sacral vertebrae, which are all fused together, and then you have 4 coccygeal vertebrae, okay, or in your coccyx. Now, the way I like to remember these, I know this doesn't necessarily break these down in the pelvis area, but a good way to remember them is, all right, cervical vertebrae. Okay, we'll start at the top. I like to eat breakfast at 7 a.m. Okay, thoracic vertebrae, 12. I like to eat lunch around 12. Okay, lumbar vertebra. Okay, I like to eat dinner around 5. Okay, and then the rest of them, I know it doesn't break it down, so you'll have to remember this your own way, but I like to go to bed promptly after Matlock at 9. All right, so 9 remaining. So 7, 12, 5, and 9. However you guys want to remember that is fine. Okay, but that's like a little trick that helped me. Hey, breakfast at 7, lunch at 12, dinner at 5, bed at 9. However you guys need to remember that. But just a way to remember: 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar, 5 sacral, and then 4 coccygeal. All right, now with the spinal column houses the spinal cord. Okay, makes up nerve tissue. Now the spinal cord, runs from the brain all the way down to about the L2 vertebra. Okay, so from the L2, it actually starts to branch off into a thick bundle of nerve roots called the caudal equina. All right, so they call it caudal equina because it kind of has the look of like a horse tail. All right, but so that spinal cord, nice cord, goes down to about the L2 and then terminates to a bunch of nerve roots that branch off from there to the caudal equina. Now we have spinal cord tracts. Now we have motor tracts that carry impulses to the same side of the body. Okay, albeit, okay, the left side of your spinal cord is going to be carrying messages for motor movement, okay, to the left side of your body. Pain tracts carry impulses from the opposite side of the body, so left side of the spinal cord is going to carry pain sensation from the right side of the body. All right, and then light touch tracts carry impulses from the same side of the body. So left side of the spinal cord is going to carry light touch sensation from the left side. Be it, let's say you have an injury to the left side of your spinal cord. Okay, left side of the spinal cord is damaged, so we know, okay, same side is going to be affected here. So we are going to lose motor and light touch on that left side. All right, but what about the right side? Even though we have damage to the left side of the cord, our patient might be able to move their right arm. They might be able to feel light touch, but they might lose sensation to pain because their pain tracks are carried from impulses on the opposite side. All right, now common mechanisms of spinal injuries. Now, vehicle collisions are going to be the most common cause. Now, 85% of patients with spinal fracture or dislocation do not present with neurological deficit. What does that mean? That means the majority of our patients that have spinal fracture or dislocation aren't going to have those signs and symptoms. So they may have pain to the spinal area, but hey, they can move just fine. They don't have any weakness. They don't have any tingling, anything like that. And you as an EMT might think that, all right, hey, well they're probably fine. Just they're okay. I don't need to worry about it. The concern here is if you handle that patient properly, you can turn that column injury into a spinal cord injury, meaning just a little movement, in one direction or another, could cause maybe a broken vertebra to pinch, sever, cut, whatever it might be, the spinal cord, and now we can have a musculoskeletal injury turn into a nervous system injury, which we do not want. So just make sure you're handling those patients with a great level of care. Things that I've seen, working in EMS and, working in the ER now is you'll have a patient that has a collar on and they'll have the patient get up and walk to, the gurney or, walk from the gurney to the hospital bed. It's like, that's not what we should be doing. We should be making sure we move that patient as one unit, avoiding twisting and turning, things like that. So remember, 85% of patients, spinal fracture dislocations, do not have neurodeficits. So, okay, we don't want to create neurodeficits. All right, so make sure you're handling those patients with care. All right, this covers the different mechanisms of spinal injuries. Okay, flexion injury, just in a sense, chin to chest. Hyperextension, you guys can think of that as a whiplash. Okay, flexion and rotation, so chin to chest with a lateral left-right rotation. All right, compression injury, that's where, think of somebody diving into a swimming pool and compressing their spinal column together. Okay, so in a sense, you're compressing the disc together, and compressing the disc could compress the vertebrae, which could lead to vertebrae injury. All right. Distraction injury is think of that as like a dislocation from hanging. I've seen this one on the National Registry before. It's the question was very simple, and it was along the lines of what mechanism of spinal injury would you suspect in on a hanging? Okay, and the answer is a distraction injury. It was like one thing was kind of like, well, that's just kind of a random factoid in there, but they do ask these questions, so make sure you know. All right, and then penetration injury, think of that from shooting or stabbing. Anytime you have penetrating trauma that has then gone into the spinal column. Now, a column versus a cord injury. Now, column injuries, you have injury to the vertebrae. Okay, so think fractures, think dislocations. So in a sense, musculoskeletal injury. Now, like all musculoskeletal injuries, what do you have with those? You have pain, you have tenderness. All right. Now, with spinal cord injuries, that's where you now have damage to the nervous tissue. All right, nervous tissue. So with nerve injuries, you're going to see issues with movement and you're going to see issues with sensation. That's where the patient's going to be, I can't move my arms or legs. Okay, I feel tingling all over. Okay, I feel numb. Okay, I don't feel pain. I don't feel you touching me. All right, that's what we're going to see from cord injuries, whereas column injuries, it's just more that localized pain in that area. All right, now we do have complete spinal cord injuries. That's where we completely transected the cord. Okay, we lose all motor, sensory, and autonomic function below the site of the injury. So if we have a high spinal cord injury, a big concern there is we lose a lot of those vital autonomic functions. All right, so You guys maybe heard it already, but the C3, 4, and 5 keep the diaphragm alive. You have peripheral nerves that branch off of the C3, 4, and 5 vertebra from the spinal cord and innervate the diaphragm, causing inspiration. Okay, if we have a high cord injury that damages the cord in that area, we may lose impulses for the patient to take adequate volumes of air. So a lot of patients that end up having these cord injuries need to be on a ventilator for the rest of their life if they're really high up. Not only that, but we have an issue with spinal shock. Okay, so spinal shock can occur. It's where you have that initial trauma to the spinal cord, in a sense, disrupts the system. What is another autonomic function that our body has? Blood vessel control, right? So if we have that shock to the spinal cord, okay, we have that trauma to the spinal cord, that could affect vessel control. All right, so we have, like, in a sense, a vasodilation that occurs below the point of the injury, and that can cause our patient's blood pressure to drop significantly. All right, and so that's why that's considered a spinal shock. All right. Now, neurogenic hypotension. So neurogenic hypotension, kind of like what I hit on last slide, you have vasodilation of the arterioles, diminished release of epinephrine and norepinephrine. Okay, skin is warm and dry, and the pulse rate is normal. Okay, so in a sense, where is epinephrine and norepinephrine coming from? It's coming from the adrenal glands. Where are those at? Is that on top of the kidneys? Well, if I have an injury up high to our spinal cord, well, that's not going to allow us to send a message down to the adrenal gland and say, hey, I need these hormones so I can vasoconstrict and increase heart rate. So those messages aren't being sent because of damage to the cord. Therefore, we may assess our patient, heart rate's 80. Why? Because the heart runs on automaticity, has its own pacemaker built in, does not rely on the central nervous system for stimulus to function on its own. It is influenced by the central nervous system, but doesn't rely on it for adequate function. That SA node generates that nice heart rate between 60 and 100. So we're assessing that patient, heart rate's 80. They're like, man, perfect. And then you throw the blood pressure cuff on him, and his blood pressure is like 60/40, and you're like, whoa, wait a minute, that's not right. Skin signs are warm and dry. It's like, what's going on? Did you take too much of your blood pressure medicine? Uh, just kidding. But in all seriousness, it's like, well, where are these symptoms coming from? They don't align. When we think of shock, we think of cool, pale, clammy skin. We think of tachycardia, and we think of hypotension, like all these things put together. But with neurogenic hypotension, it's just a vasodilation that's occurring. Heart rate remains normal. Skin signs remain normal because we're not getting a lot of those messages being sent from, our adrenal glands to cause a lot of the other symptoms that we would have. Now, with incomplete spinal cord injuries, injury does not involve all three tracts. So, in a sense, we have presentation of some signs and symptoms, but not all signs and symptoms. Now, the pattern of loss function is reflected in different syndromes. Okay, things like central cord, Brown-Séquard, and anterior cord syndrome, which we'll discuss. Okay, so with central cord syndrome, okay, that's where that medial or the inner portion of the spinal cord is injured. Okay, with anterior cord syndrome, that's where the anterior or the frontal aspect of the spinal cord is damaged. And Brown-Séquard syndrome, that's where we're dealing with the left or the right side of the spinal cord being damaged. Now, with central cord syndrome, so central cord, we have that inner portion of the spinal cord is damaged. Now, the inner portion has motor and pain tracts that control the upper extremities. Okay, the lateral or outer aspects of the spinal cord have tracts that control the lower extremities. So, with central cord syndrome, you have the inner portion is damaged. So, what you are in a sense going to see from central cord syndrome is a patient that has function of their lower extremities. Like, hey, they're walking around, they can feel you, they can wiggle their toes, all that good stuff. Okay, but then they lose motor and pain track to the upper extremities. So their arms are just like at their sides, they can't move them. That's kind of different presentation from what you would think with a spinal cord injury, right? You think everything below the injury site is, is damaged. All right, well, hey, if the arms aren't working, the legs shouldn't be working. Well, it just could be an incomplete cord injury specifically to the center portion of the spinal cord. Now, anterior cord syndrome, we have loss of function in motor and pain tracts, but not in light touch tracts. Okay, patient experiences paralysis and inability to feel pain below the level of the injury, but can still feel light touch. All right, so that's just where a good, neuro assessment on your patient, it just could show how much is damaged, with their cord. At the end of the day, guys, as an EMT, you're not out there to diagnose. Looks like anterior cord syndrome. You're not going to be out there to diagnose them. Okay, this is just going to explain, like, hey, why am I seeing this? Like, why can my patient, not move and not feel it when I pinch them really hard? But then when I like slowly like glance the bottom of their foot, they could feel it and they say, like it kind of causes them to feel like a tickle sensation. It's like, well, because they might have a incomplete injury. All right, now Brown-Séquard syndrome, the injury affects only one side of the cord, and so loss of motor and light touch sensation on the affected side, and loss of pain sensation on the opposite side. I gave this example in the beginning. So if like the left side of my spinal cord's been damaged, like penetrating trauma, okay, left side of the cord's been damaged, I'm going to lose motor and light touch on the left side, but I'm going to maintain, okay, that motor and light touch on the right side. But on that right side, I'm going to lose sensation to pain. All right, so click on the finding that would most, nice little spelling error there, would be most consistent with central cord syndrome. Okay, central cord, so medial aspect of the spinal cord, innermost aspect, so loss of movement, light touch sensation below the site of the injury on one side, loss of pain on the opposite side. Let's see what B is. Loss of motor and sensory function on both sides below the injury site. Let's see. Weakness and loss of pain sensation of the upper extremities with no weakness of the lower extremities. And then the loss of motor function and sensation of pain on both sides below the injury site, but retention of light touch. Okay, so let's break her down. Now, central cord, inner portion of the spinal cord is what we're talking about here. What you got to think of, get inner portion, that's carries control to the upper extremities, where the outer portion carries control to the lower extremities. So what we would be looking for is upper extremities that are compromised, lower extremities still intact. Now the one that most jives with that, okay, is going to be C, weakness and loss of pain sensation of the upper extremities with no weakness of the lower extremities. All right, so assessment-based approach. All right, guys, in a sense, high index of suspicion is what you need. High index of suspicion is what you need. Just don't think that everything's okay because the patient's up and walking around. All right, why? Because they can have a column injury. They can have so much adrenaline going through their body following a vehicle rollover, and they're up and walking around and just trying to settle themselves down by the time you approach the scene that they might not necessarily feel the pain. Okay, so high index of suspicion, don't just assume that everything's all right. And now with these crashes, falls, blunt penetrating trauma, sports and recreational injuries, gunshot injuries, think about that. Especially with high velocity rounds like rifle rounds. It's not just the trajectory that round takes through the body, right, that we're worried about. What else are we worried about? We're worried about cavitation, that secondary wound cavity that gets created from the transfer of energy into the body. So even though that round may not have hit the spinal cord, you could still have damage to the spinal cord because of cavitation from the round transferring energy into the person. Okay, and electrical injuries, guys. Electrocution can be devastating. All right. Um, Now, I watched a video the other day of an individual talking through like his failed attempt at some electrical job that he had in his in his backyard. Long story short, the electrocution that he was suffering, it caused him to tense up so much that it actually like blew out muscles and turned him into a projectile in a sense, and caused a significant amount of trauma. So if you have an electrocution, you guys should, we're worried about the heart, we're worried about breathing, but we're also worried about musculoskeletal trauma. All right, so mechanism of injury heightens your suspicion that potential injury might have occurred. Okay, it does not provide evidence that injury occurred. What does that mean? It means you need to assess your patient still. All right, now deduce the mechanism of injury from evidence at the scene to determine if such mechanism could have injured the spine. All right, so I walk up, I'm at a vehicle collision. All right, I see starring on the windshield. All right, well, at that point, I need to be thinking based off the mechanism that, all right, my patient's face probably hit the windshield. My patient probably has facial injuries and spinal cord injuries. Now, does that automatically mean that the patient's face hit the windshield and they have facial and spinal cord injuries? What if it was the, giant Yeti mug that they had that hit the windshield? Just saying that could be that could be a scenario. So what do you need to do? You need to then assess the patient, right? So that's just, we're thinking based off what we're seeing with the scene characteristics that I have these kind of injuries, but ultimately I need to assess the patient to find out if those injuries are present. All right, so I come up on scene. I'm assessing my scene. What do I see? I see significant intrusion into the vehicle. All right, based off the mechanism of injury. All right, I would be thinking in my mind, my patient's going to be, injured, possibly facial injuries, neck injuries, and so on. Okay, possibly see, I think maybe airbag deployment in there. All right, so the higher velocity, as far as the trauma goes. So again, just using our scene characteristics to get an idea of what we can expect with the patient. What do we need to do? We still need to assess the patient. All right, so with our primary assessment, now with a mechanism of injury consistent with potential spinal cord injuries, we need to immediately go in and hold inline manual stabilization. Okay, that's being, okay, you have an individual who goes in there, please don't move your head, keep your head still, but make sure the head's in anatomical position, all right, and hold their head still. And then anytime we move the body as a unit. All right, we don't want to have twisting or anything like that could possibly injure the spine. When we have to open an airway, we will use the jaw thrust maneuver to open the airway. Okay. Ultimately, you're going to follow local protocols for spine motion restriction, meaning this is going to vary from where you go. When I worked on the ambulance, it was a while back, and I can tell you, trauma is like, man, you were getting the collar, you were getting the backboard, and in trauma assessments in class, even like when I was an EMT, or when I was an EMT student, it was like if you didn't backboard your patient during a trauma assessment, for testing, it's like that was an automatic fail. And it's like, well, my patient with an isolated tip fib fracture, my assessment doesn't necessarily need to get backboarded, right? So we've changed, and we've seen a lot of change in EMS as far as what we're going to be doing. So just be abreast of your local protocols, because those are going to dictate everything that you're going to do, meaning a backboard. A backboard may only be used to move your patient. Okay, there are a lot of agencies that have found that if putting a patient on the backboard actually increases the risk because they're not comfortable. The patient ends up moving a lot, and that opens them up to injury. So they just put them on the gurney with a collar on to limit their movement in the neck area. All right, and then lay them on the semi-rigid gurney. Okay, versus a complete backboard, and they only use the backboard for transportation of the patient from, say, the ground to the gurney. So just make sure you're aware of your area's protocols. That doesn't help me for the test. So, in your primary assessment, perform manual stabilization of the spine based on the mechanism of injury. Okay, maintain manual stabilization of the spine until a thorough assessment does not reveal indication for motion restriction or spine motion restriction has been accomplished. Okay, spine motion restriction, it could be just placing a C-collar on the patient and then placing them on the gurney to limit motion. All right. It could be you work in a place that still requires full backboard immobilization of the patient. Just know that you have to hold inline stabilization until spine motion restriction has been accomplished. So that person needs to be holding their head until you've, reduced motion of the spine. All right. Whatever your protocol dictates. If it's full backboard immobilization, then fine. It's full backboard, collar, and the works. If it's just the collar and on the gurney, then fine. It's just the collar and the gurney. Now, maintain stabilization until the assessment does not reveal indications for motion restriction. So you come up on scene, you're like, all right, I am thinking that my patient possibly needs spine motion restriction, so we hold it. Now, you're assessing the patient, and it's a 20-year-old who had a fall in a grocery store from standing height, denies any head, neck, back pain, denies any loss of function, to motor sensory anywhere in their body, denies numbness, tingling, anything like that. Their right wrist hurts because they put their wrist down to break their fall. All right. Well, I can, based on my assessment of that patient, no spinal injury, isolated, like wrist injury, fall from standing height. The mechanism doesn't necessarily warrant, uh, the concern for spine injuries. Based off everything that I'm seeing, because I'm taking my patient as a whole, I can, we don't need to hold C-spine anymore. All right, so remember, it's based on you. You need to do a thorough assessment to make that determination. And it's going to fall on you as an EMT or the provider if you don't do it and they needed it. So this is where it gets kind of in that gray area. But just be aware of that. Like, not everybody needs a full backboard and collar. All right, not all your trauma patients do. But just trust me, if the patient's having any neurodeficits, if they had a significant MOI, like if your patient's been ejected from the vehicle, where they got adrenaline like pumping through their body, and they're like, no, I'm fine, I'm fine, I'm fine. Hey, still take spine motion restriction. Why? Because they were just launched out of a vehicle, and that's a pretty crazy mechanism of injury. Hope that makes sense. All right, now, provide spine motion restriction on patients with positive mechanisms of injury who have altered mental status, have painful distracting injuries, and cannot effectively communicate with you. All right, so there we go. There are some reasons to take spinal precautions. Altered mental status, what's that telling you? All right, there is significant force to affect function of the brain, right? Distracting injuries, all right? Hey, if their freaking legs are bending the wrong way and they got bones sticking out, all right, guys, that may take away from, that back pain that they're also having, okay? Cannot effectively communicate with you. Now, if you guys can't ask them about pain, then you don't know where pain's located, all right? So make sure you're protecting the patient. Okay, high priority patients are ones that are unresponsive, responsive, but unable to obey commands, have abnormal breathing pattern, and obvious signs of spinal injury. So paralysis, would be an obvious sign of spine injuries. Okay, your secondary assessment, maintain inline spine stabilization, conduct a physical exam. Do a thorough physical exam on this patient, okay? Go head to toe, assessing cap refill, motor, sensory, pulses. All right, assess that patient. Or check pain stimulus, check light touch stimulus. Okay, it's real quick. It doesn't take time to pinch a nail bed. Can you feel that? And they're like, yes. Okay, and then slide your finger across the top of their hand. Can you feel that? All right, no. All right, so it doesn't take time, but make sure you're assessing those things. Make sure you're assessing pain. Make sure you're assessing light touch. Can the patient move their fingers? Okay, can the patient squeeze your hands? Okay, those are ways to assess motor function. Okay, after assessing the neck, apply a C-collar. All right, so after you assess the neck, that's where you can put that collar on. Just you want to make sure the neck is exposed so you can do an adequate assessment of it. All right, with your posterior exam, we want to log roll the patient. So log roll the patient so they're moving in one motion. All right, we want to move them in a unit. We do not want to twist. We do not want to rotate them at all. Okay, always going to be controlled on the headman. So the headman is going to, do the roll. Okay, we're going to roll the patient on 3. 1, 2, 3. Okay, and then you can assess the back. Okay, assess your baseline vital signs. Now, if the brain or spinal cord is damaged, vital signs might reflect neurogenic hypotension. What is that again? All right, that is where your patient has a normal heart rate. Hey, skin signs are normal, but their blood pressure is really low. Remember, that's not making sense when you're assessing. I'm thinking my patient's in shock. All right, I should have tachycardia. I should have cool pale clammy skin. All right, and hypotension. All right, well, it could be the damage to the spinal cord, right? That's just affecting blood pressure. Now, if hypotension is severe and the patient has tachycardia, suspect bleeding as the cause of shock. All right, so meaning if you're getting those classic signs and symptoms of shock, be on the lookout for like bleeds, because that could be what's giving you those signs and symptoms. All right, so your secondary assessment history. Obtain a history from the responsive patient. Assess for allergies, medication, past medical history, last food, drink, events prior onset of signs and symptoms. All right, now guys, with our trauma patients, especially your critical trauma patients. Guys, I'm doing my primary assessment. I'm doing a physical exam, my secondary assessment, and then I'm going to try to obtain as much history as I can without delaying transport of my patient, especially if they're critical. So a lot of the stuff you may be getting en route to the hospital, all right, if the patient's able to talk to you, okay, are getting from family members as you're loading the patient. In a sense, guys, you're not wanting to delay transport of a critical patient, to find out it's like, hey, do they have any allergies? Hey, let's go find the family member to see if they ate or drank anything. Hey, is that important? Yes, it is. But the important thing is a critical patient getting to definitive care. Okay. Now, again, why this stuff's important? Past medical history. Hey, if my patient has right-sided deficits, right, like they can't move their right side of their body, and I'm like, oh my gosh, they just had a fall, well, is that right side deficit normal for the patient because they had a stroke 2 years ago and they've always had that paralysis on the right side? So again, that's where kind of past history, onset of signs and symptoms, what's going on, that information can be important to you. All right, now with our signs and symptoms, tenderness along the spine, pain associated with movement, pain independent of palpation or movement, deformity of the spinal palpation, and soft tissue injuries. Now, that can really coincide with your spinal column injuries, right? I remember I had a patient, it was very early in my EMT days, and we were palpating the back of the patient's neck. Now, she wasn't complaining of any pain except for when we started palpating the back of her neck. And when we palpated the back of her neck, we found step off. All right, so it's like where there's like a dislocation of the spinal column. We found that, and I was like, oh crap! All right, let's make sure we're moving this patient carefully because we definitely don't want to. She had full movement, everything else was good. There was just a step off present and pain on palpation. So make sure you're doing that thorough assessment. Okay. Other signs and symptoms: numbness, tingling, weakness, loss of sensation, loss of bladder or bowel control, priapism, impaired breathing. So now we're moving from the range of, column injury now into a cord injury. All right, numbness, tingling, loss of bladder, bowel control, priapism, in the sense of erection, okay, and impaired breathing. Now, hey, we're looking at cord injury versus column injury. Okay, now assessment findings that are indication for spine motion restriction. Here we go. Indication for spine motion restriction, GCS of less than 15, altered mental status, suspected traumatic brain injury, pain or tenderness of spinal column, paralysis, weakness, numbness, tingling. I'm sure you guys are all getting this. Okay, deformity of the vertebral column, under the influence of drugs or alcohol, cannot communicate effectively, and has a painful, distracting injury. All right, so a lot of different things to look at with these patients. Just if in doubt, protect the spine. Okay, if your patient's walking the line, it's always better to give care than to withhold care. All right, hopefully that's something that you guys have gotten up to this point in class. It's always better to give care versus withhold care for that patient. You know, worst case scenario, you put a collar on them. It's uncomfortable. They get to the hospital, they go in for X-ray, nothing's wrong, and the doctor clears them of a collar. Versus you like, I don't know, they've only had a little bit to drink. The fall wasn't that bad. And then you bring them to the hospital and they go in for X-ray, and then they have a broken neck. You know, that stuff happens. So make sure you're erring on the side of care. Okay, now complications of spine injuries, inadequate breathing effort. Remember, C3, 4, and 5 keep the diaphragm alive. Those peripheral nerves from C3, 4, and 5, the phrenic nerve, innervates the diaphragm, causes good respirations because there's good tidal volume. All right, if we don't have that, all right, our patient doesn't breathe adequately. So respirations may be shallow with little movement of the chest wall or abdomen. At that point, guys, positive pressure ventilations, right? We need to make sure we're breathing for the patient. Okay, other complications include paralysis, paraplegia. Okay, that's where you're just two extremities paralyzed, quadriplegia, all four, hemiplegia, half of the body, so left half or right half, okay, is paralyzed. Now, common in head injuries and stroke. All right. All right. So emergency medical care, guys, standard precautions. All right. Make sure you're wearing your PPE, gloves. Today's day and age, everybody wears masks now. And then first thing you're doing when you're coming up to that patient, you know, after you've done your scene size up, approaching the patient, getting your general impression, like, do not move your head. Okay. And then you're taking inline stabilization to reduce further movement. There you go. Coming up, taking manual inline stabilization. Okay, head goes into an anatomical position. Okay, if you need to open the airway only with a jaw thrust and provide positive pressure ventilations as clinically indicated. Okay, suction secretions without turning the patient's head. So, if you have copious amounts of secretions, like they are coming out, they're vomiting. All right. And you need to move the patient because suction's just not enough. You need to log roll the patient as a unit. Okay. Log roll the patient as a unit, not just turn the head because we don't want to damage their spinal cord. Okay. Assess pulse, motor, and sensory function. Assess the neck before applying the cervical collar and then apply the cervical collar. Can't emphasize this enough. Please make sure you size your cervical collar appropriately. Now, this PowerPoint presentation is not going to teach you about, sizing and putting a collar on. That is what your skills are for in class. If you are uncomfortable applying a collar or sizing a collar, you get with your skills instructors to put that collar on, guys. Practice, 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 getting your hands on the equipment, okay, and making sure you know how to do that. I've seen so many times patients come in with an inappropriately sized collar or a collar that's not put on correctly, like where the patient's chin is like underneath where their chin should go. All right, or the collar is like wrapped around their head and face. I've seen it. It's crazy. Also, your collar shouldn't be so big to where the patient's in a head tilt chin lift position because it's pushing their chin up because it's inappropriately sized. All right, now provide spine motion restriction of the patient on a long backboard. Remember, that's going to be protocol dependent now. after placement on a backboard, reassess pulse, motor, and sensory function. Anytime you guys have moved a patient, especially one that has spinal injuries, you guys want to recheck CPMS. All right, you want to recheck CPMS to make sure we haven't lost anything in movement. Okay, so you go and move that patient. If you don't put them on a backboard, you move them onto the gurney, or however you move them, you log roll them. Okay, make sure you're rechecking CPMS. Okay, and then transport the patient. All right. Now, guidelines for spine motion restriction. Now, here's a historical perspective. Now, this, a little dated at this point, but we're looking at spinal mobilization versus spine motion restriction. Spinal mobilization, where that patient was like strapped to a backboard, completely secured down onto the long backboard, and like there's no movement. Like, where are you going? Nowhere. All right. Now, until 2013, immobilization was a standard. All right. So before that time, hey, that's when I was, going through EMT school. Everybody got backboarded. Everybody got backboarded. Everybody got a collar. It's like, and I remember for some patients, like, even when I was on the box and on the ambulance, man, like it was a painful experience for patients. Like I remember, cruising through Hemet, down Florida's like great water control system, like through intersections and trying to drive slowly. Speed limit's 45, I'm going like 25, and the roads are just not great. And man, every bump on that backboard, it was uncomfortable for a patient. So we've studied this and we've looked at it. So mobilization was the standard until 2013. Okay, for any patient found to have an MOI, which may result in spinal injury. But what we looked at is that a lot of our patients didn't necessarily need all of that. Okay, so what we did is we looked at that system that we had, and it was like, man, our patients were doing more harm than good with these backboards. Patients on a backboard, they won't sit still, they'll shift, they'll move, push them at risk for a spinal column injury, right, from additional movement. We don't want that. Okay, so we looked at, okay, how can we change this? So instead of immobilizing patients, we looked at spinal motion restriction, putting the collar on a patient and then putting them just on the gurney on the same bed that we've been using, same cot that we've been using, but putting them on that. Trust me, guys, it's not like a big soft, Serta mattress that they're laying on. It's still relatively firm, relatively stable. All right, so it does give us a level of protection. Now it's a bit more comfortable for the patient, so they're not moving around as much, lowering the risk for pressure injuries on the patient. All right, so in a sense, it was a better way of care, and that's what we then transferred to. Now, longboards, get used for more significant traumas, okay, are just simply moving the patient, from point A to point B. Now, indication for spine motion restriction, I know we've kind of hit on this, but follow local protocol, use criteria to clear the spine, all right? And again, local protocol is going to dictate, but with this, you're looking for things like neurological deficits, all right? You're looking for spinal cord tenderness or spinal column tenderness. So, hey, does my patient have any paralysis, weakness, tingling? When I palpate the back, does the patient have any pain or tenderness as I'm palpating along the back? Is the patient intoxicated? Does the patient have any distracting injuries? Okay, how old is my patient? I'm looking at all of those things. So if my patient has no neurodeficits, they're not intoxicated or under the influence of drugs or alcohol, they're alert and oriented times 4. They have that isolated wrist injury from a fall from standing high. It's like, all right, I can, clear the spine at this point. Just understand that unreliable patients with a qualifying mechanism of injury must be provided with spine motion restriction. Okay, so your high velocity mechanisms, okay, vehicle collisions, okay, ejections, gunshot wounds, okay, those are all qualifying mechanisms of injury. So make sure you're assessing the patient, make sure you're assessing your MOI. Please don't be the one to go up to the vehicle collision where your airbags have been deployed, patient's been ejected, and they're like, go ahead and walk to the ambulance. Guys, that's a pretty significant MOI that would justify spine motion restriction. All right. Now, spine motion restriction necessary for unreliable patients, patients with neurodeficits, spine pain or tenderness near the vertebral column, and distracting injuries. Okay, spine motion restriction not necessary for reliable patients that communicate with you effectively, and then no pain or tenderness to the spine, no neurodeficits, and no distracting injury or any intoxication. Okay, again, I'm sorry. This is a big complaint that we get from students. It's like, well, why are you telling me about protocols? Because it says in your protocol or in your book, protocols will dictate what you do. Okay, so that's why we hit on protocols a bit. Guys, just be aware of where you're working and what they want you to do. Okay, because you are functioning, remember, under a provider, under a doctor's license to practice medicine. You are working under that medical director. So he dictates or she dictates what you are going to do. Okay, so make sure you're following your protocols. All right, so here's an example of a normal spine. Okay, look at that, nice and connected. Okay, we're not connected anymore. All right, so this would be an example of step off. Kind of shared a little story that I had where I was, palpating along the patient's neck, palpating down. It's like, I felt a distinct deformity in the back of the neck. Okay, step off. That is an issue. Okay, so if you find something like that, hey, boom. Okay, spine motion restriction. All right, make sure you're holding inline stabilization of the patient. All right, so hitting in on some special considerations. Now, helmets. First, assess the patient wearing the helmet, right? Assess mental status, assess your ABCs, assess the fit of the helmet, and then determine your ability to gain access to the patient's airway. Meaning, okay, they have an injury, but if the helmet's secure in the head, it fits well, I can access the airway if needed, okay, then I might leave the helmet in place to keep the head and body aligned. A good example of this would be football, right? You see football players that get spinal injuries, and what do? They leave the helmet on. They leave the helmet on, they leave the pads on. Why? Because it keeps that spine in a nice neutral inline position. They take the helmet off, that head's going to fall back, and then they need to pad underneath the head. So they just keep it on and remove the face mask. All right, so those are things that they consider. Why? Because it keeps everything nice and straight, nice and in line like we want it. Okay, now leave the helmet in place if the helmet fits well. There's little or no movement, no airway issues. Okay, leave the helmet on if removal of the helmet will cause further injury. Remember, we don't want to do any additional harm to the patient. Now, you can provide spine motion restriction with the helmet on, and it doesn't interfere with your ability to reassess the airway and breathing or provide intervention to the patient. All right. Now remove the helmet if it's going to be the opposite of what we just talked about. If you guys cannot assess airway breathing, if you guys cannot provide airway and breathing interventions, okay, if the head moves around in the helmet needs to come off. If you guys can't stabilize the neck and provide spine motion restriction with the helmet on, it needs to come off. And then obviously the patient's in cardiac arrest. Now, the patient's in cardiac arrest because you're going to need access to airway and breathing stuff. All right. Now, basic types of helmets. You have sports helmets and motorcycle helmets. Now, with your sports helmets, face masks and football helmets can be removed by cutting the plastic clips. Guys, a lot of times go with like the athletic trainer, okay? Because they have a lot of times these little handheld drills that will quickly remove the face mask. All right, where you're not having to like cut plastic clips off of the helmet with things like your trauma shears. Okay, so there'd be an athletic trainer oftentimes already there. They might have equipment available for you to remove that face mask. Now, with motorcycle helmets, now I will tell you that there are emergency clips. There are little things like where they can inflate air into the helmet to make them fit. Just look for those emergency clips, things that you can let air out of the helmet, so that way it makes it easier for the helmet to come off. Those things are expensive. Remember, being a patient advocate, obviously you're going to worry about the patient care aspect first, but little things, like, cause I have had patients very upset because I've cut stuff off of them. Like, I had a patient legit broken back, upset because we cut off their expensive PPE. So, if you can, guys, there's like, little emergency clips to just undo a thing versus cutting and totally destroying their helmet, even though their helmet should be no good if they've been in an accident with it. Just a consideration. Now, equipment intensive sports. So important that the athletic trainer and the EMT be prepared to work together. Okay, when appropriate, helmets and shoulder pads should be removed before transport. Now, removal should be performed by a minimum of 3 trained rescuers. Now, what do you see though? What you see in real life is you see a lot of that stuff being kept on during transport because they're able to adequately transport the patient and immobilize the spine or provide spine motion restriction with the equipment on because they can access the airway and all that stuff still. Okay, so several tools can be used to remove the face mask, spine motion restriction, remove the face mask and helmet, pad beneath the head, remove the shoulder pads and pad, apply cervical collar. All right, that is if you're going to remove everything. Understand, guys, if you take the helmet off, you need to pad underneath the head. All right, or you need to work at taking the shoulder pads off also. Okay, because we want to keep the head in a neutral inline position. If we do one and not the other, or we don't pad, that's going to put the head in an awkward position. Okay, now with spine motion restriction for infants and children. So with kids, oftentimes you may need to pad underneath the shoulder blades to keep the head in a neutral inline position. All right. Make sure cervical collar fits before applying it to the infant or child. All right. Again, I've seen a lot of inappropriately sized and inappropriately placed collars. If you don't have a collar that's going to fit for the patient, don't put on an inappropriately sized collar. Improvise something to keep the head stable. Guys, things like rolled towels, okay, will work a lot better than a gigantic collar on a little baby's head. Okay, it's just because you're wanting to keep the head in a neutral aligned position and you're wanting to provide some stability to the neck. So don't use inappropriately sized equipment because you're putting the patient at greater risk of harm there. Now, extricate the patient from a car seat. Now, if you have a car seat in a vehicle and there's been a traffic collision, oftentimes that car seat is no longer going to be a viable piece of equipment that you can use. All right, there are special rules. I think it's DOT or National Highway Traffic Safety. They have rules for like when you can use the car seat, and like the vehicle needed to be able to drive away from the accident. There needed to be no damage to the side of the vehicle the car seat was on. There needed to be no injuries to any of the occupants in the vehicle. Like, there's a criteria to use the car seat that was in the car. Now, if the vehicle's able to drive away, there's no injuries to anybody. It's like, why are you there then? You're there because there are probably injuries, right? So at that point, guys, you can't use the car seat. So you'll need to extricate the patient from the car seat. The best way to do that is to move the patient in a way that is straight out of the seat. I think I got some pictures coming up to show you. All right, so notice we have our provider here providing axial stabilization, keeping the head in a neutral and line position. Guys, car seat's been an accident. We're not using it anymore, so we can just cut that. All right, cut these little straps right here so we're not needing to move anything over the patient's head. Okay, notice we applied a collar. Now we've obviously assessed the neck already when we've applied this collar. Okay, still holding spine motion restriction because we're not done, right? We're still holding the axial stabilization because we're still manipulating and moving the patient. All right, what you can then do is you can lay the car seat back. All right, obviously we remove the car seat from the vehicle, lay the car seat back, and then we're moving the patient in a straight line. This is a pediatric board onto the pediatric backboard. This is a much better way of moving the patient versus like twisting or grabbing and pulling them out of the board or of the car seat. Also, the one thing I'll say here, I don't have the video of them moving, but this person holding the head should just be supporting the head and holding it in a neutral inline position. There should be no pulling, pushing. Hopefully that goes without saying. Okay, moving the patient straight out. All right, so lesson summary, spine injuries can lead to permanent disability. In a sense, our goal is to reduce the risk of that. Okay, proper management to avoid movement of the spine is imperative. Why? Because we do not want to cause permanent disability. It would really stink for a patient to have motor sensory function and then we get there and we do something to harm the patient. So spinal cord injuries can be partial or complete. Guys, go back and make sure you know central cord syndrome, anterior cord syndrome, and Brown-Séquard syndrome. You will see questions on your exam on those. Okay, so make sure you can, if they give you some signs and symptoms, make sure you can identify the proper injury. Okay, spinal cord injuries can cause loss of motor and sensory function. Okay, and then complications of spinal cord injuries include respiratory failure and neurogenic shock, or that neurogenic hypotension. Remember, neurogenic shock, neurogenic hypotension doesn't present like your typical shock. So no tachycardia, no cool pale clammy skin. If you do have those things, then you should be suspicious that there's bleeding occurring somewhere.